Hello everyone. This time we have a new addition. We are introducing a new series of audio guides linked to our surgical videos on YouTube, in addition to the article based podcast episodes. Each episode explains the surgical video and the relevant anatomy and operative steps. The podcast is intended as a companion to the visual demonstration, not as a replacement for it. You can access the surgical complete video through the YouTube link provided in the episode description. In this episode, we discuss the anatomy, surface marking, and step-by-step harvest of anterolateral thigh flap. The ALT flap is one of the principal workforce flaps for head and neck reconstruction. It can provide a large skin paddle, variable soft tissue bulk, a long vascular pedicle, and relatively low donor site morbidity. Depending on the defect, it may be harvested as a faciocutaneous, adiposofacial, or myocutaneous flap. Separate skin, fascia, and muscle components can also be raised as a chimeric flap. Let's begin with the vascular anatomy. The ALT flap is usually supplied by the perforators arising from the descending branch of the lateral circumflex femoral artery. This artery commonly originates from the profunda femoris system. The descending branch travels distally in the intramuscular plane between the rectus femoris medially and the vastus lateralis laterally. It is accompanied by two venae comitantes. The cutaneous perforators may be septocutaneous or musculocutaneous. Septocutaneous perforators pass directly through the intramuscular septum. Musculocutaneous perforators traverse the vastus lateralis before reaching the skin and are encountered more commonly. These require careful intermuscular dissection. The motor nerve to the vastus lateralis may run close to, cross, or even interweave with the vascular pedicle. Its branches should be preserved whenever possible. The lateral femoral cutaneous nerve may be included when a sensate nerve is required. For surface marking, place the patient supine and expose the entire thigh. Mark the anterior superior iliac spine and the lateral border of the patella. Draw a straight line joining these two landmarks. This represents the approximate axis of the intramuscular septum for the ALT flap. Mark the midpoint of this line. The dominant perforators are commonly located near this midpoint, although their position and vascular origin can vary. Examine the surrounding area with a handheld Doppler and mark all suitable signals. This is called as a perforator zone, marked as a circular area with the midpoint along the initial straight line between anterior superior iliac spine and the anterosuperior patella. Design the skin paddle along the axis of the thigh and center it on the most appropriate perforator. The paddle dimensions are determined by the reconstructive defect and the amount of tissue required. But if possible, try to primarily close the defect. Harvest commonly begins with a medial incision. Divide the skin and subcutaneous tissue and identify the fascia lata. For a convenient faciocutaneous flap, incise the fascia and elevate the flap from medial to lateral in the subfacial plane. As the dissection proceeds laterally, identify the rectus femoris. Retract it medially to expose the plane between the rectus femoris and the vastus lateralis. The descending branch of the lateral circumflex femoral artery can usually be identified within this plane. Continue elevating the flap carefully until the perforators enter its deep surface are visualized. Avoid excessive traction or thermal injury in this region. Each perforator should be assessed for size, pulsatility, position within the skin paddle, and course towards the source vessel. A septocutaneous perforator can usually be followed directly through the septum. For a cutaneous perforator, split the fibers of the vastus lateralis in their natural direction. Trace the perforator retrogradely through the muscle. Small muscular branches are individually clipped or coagulated away from the main perforator. Avoid pulling or rotating the perforator during this dissection. If the perforator is small or has a difficult intermuscular course, retaining a small cuff of vastus lateralis around it may be safer than complete skeletonization. After confirming a reliable perforator, complete the lateral incision and island the skin paddle. Trace the selected perforator proximally until it continues or joins the descending branch. The main pedicle is then dissected proximally between the rectus femoris and vastus lateralis until the required vessel length and caliber are obtained. During the pedicle dissection, identify and preserve the motor branches supplying the vastus lateralis. Unnecessary proximal dissection should be avoided once sufficient pedicle length has been achieved. Before dividing the pedicle, confirm bleeding from the flap margin, satisfactory perforator pulsation, and adequate venous drainage. Check that the pedicle is free from tension, compression, or twisting. The recipient vessels should ideally be prepared before the pedicle division. The artery and venae committents are then divided at the required level, and the flap is transferred to the reconstructive site. Clearly marking the pedicle and skin paddle orientation helps prevent twisting during inset and microvascular anastomosis. Finally, obtain meticulous hemostasis at the donor site, place a suction drain, and close the wound in layers. Primary closure should only be performed without excessive tension. If closure is tight, a split thickness skin graft is preferable. In summary, successful ALT flap harvest depends on accurate surface marking, careful perforator selection, meticulous intramuscular dissection, and preservation of the motor nerve to the vastus lateralis. Its versatility, long pedicle, and adaptable tissue components make the ALT flap particularly valuable in head and neck reconstruction. Thank you for listening. The accompanying operative video is available through a link in the episode description. Signing off, Head and Neck Oncology Journal Club. Thank you.